My pleasure. Good morning and good evening to our participants overseas. My name is Marah Hehemann, and I'm an assistant professor of urology with a focus in men's health at the University of Washington. And today I'll be speaking about erectile dysfunction, mechanisms, and management. I want to thank IVU for the opportunity to speak here today and really welcome everyone to the call. It's a pleasure to be with everyone. So here are my disclosures. Our objectives today are to define the scope of the condition of erectile dysfunction. I'd like to identify the major causative factors and then describe a guidelines-based approach to evaluation and management. Lastly, I'd like to discuss the new frontiers in treatment and then open it up for questions about anything from practice here in Seattle to further talk about ED. So erectile dysfunction is extremely common. We know that it increases in prevalence with age and that 30 to 50% of men ages 40 to 70 have ED. Global prevalence has been identified as up to 76.5% of men and is correlated with age and health status. We also know that severe ED increases with age. There's also an increasing awareness of erectile dysfunction since the late 90s. Or Viagra was FDA approved in 1998. And at that time, we saw a real escalation in direct-to-consumer advertising. By 2005, Pfizer and Eli Lilly, which are the pharmaceutical producers of Viagra and Cialis, were in the top 20 spenders on direct-to-consumer ads, spending up to $190 million just that year. And what we also know about the media is that it portrays erectile function to be something that should be spontaneous and easy to achieve. But as urologists, we know that the erectile machinery is actually very much more complex and relies on perfect elements coming together to achieve an erection. Elements like vascular health, healthy penile tissue, neurologic function, endocrine function or testosterone, and mental health free from anxiety. So ED can be attributed to a number of these mechanisms. Disruption anywhere along the anatomic circuit can result in ED. For instance, central or peripheral nerve injury, as in the setting of prostatectomy, can result in neurogenic ED. Abnormal arterial inflow or disrupted venous trapping due to cardiovascular disease or diabetes can also make it difficult to achieve or maintain an erection. And high anxiety states also contribute significantly to ED, especially in my opinion here in the United States in young men. There is a specific pathophysiology of cardiovascular disease and ED where we know that they share a common element, which is endothelial dysfunction. So there are a number of risk factors that contribute to endothelial dysfunction and atherosclerosis that are common to both cardiovascular disease and ED. And these are things like smoking, obesity, sedentary lifestyle, alcoholism, psychological stress, and other medical comorbidities like hypertension, diabetes, and hyperlipidemia. And so yes, ED is a marker of overall wellness. There is an increased risk of premature mortality with a hazard ratio of 1.7 for men with ED versus those without. And there's also an increased risk of 1.4 times the risk of cardiovascular disease related mortality for men with ED versus those without. So this problem is real and it is our duty to intervene. Also, sequelae of ED are known to extend beyond physical and sexual health. ED is a common psychological concern for men and their partners and can cause significant depression, anxiety, decreased quality of life, and a lower levels of physical and emotional intimacy in partnerships, which leads then to lower relationship satisfaction. When we treat ED, we know that we see improvements in both patient and partner quality of life and sexual function. So it is important to treat for a holistic view of men's health. So how do we best evaluate and treat our patients? Luckily, there are a number of guidelines proposed by different governing bodies of urology, including the AUA, the EAU, and the Canadian Urologic Association. And I primarily follow the AUA guidelines, being here in the United States and having this be our primary go-to guidelines focused resource. The AUA specifies that we should do, for men presenting with symptoms of ED, we should do a thorough medical, sexual, and psychosocial history, a physical exam, and select laboratory testing. They should also have a serum total testosterone in the morning. So this is what my initial evaluation looks like. I first take a very thorough history, identifying any medical comorbidities, sexual comorbidities, and evaluating their psychosocial life. So I address any orgasmic dysfunction, whether they have any evidence of Peyronie's disease or penile curvature. How is their libido? How is their sex drive? What's going on in their relationship? Did this ED have a rapid onset related to relationship stress, or has it been more gradual over time? Lastly, are they on any medications that can predispose to ED, like SSRIs or antihypertensives? I then perform a very focused physical examination, first generally looking at a man's virilization. I do a vascular assessment by checking pulses, and then I do a focused genital exam. This is evaluating the penis for plaques or fibrosis of the corpora cavernosa. I evaluate testis size for signs of testicular failure. Then I always get a morning testosterone along with an LH. I get the LH to put into context the testosterone, whether low, high, or normal. And I do consider getting some adjunctive lab testing, and I'll go into this on the next slide, including a hemoglobin A1C, CBC, lipids, and a BNP, just as kind of a general screening. This is part of a cardiovascular risk assessment. As we know, ED commonly precedes cardiovascular disease, and I am particularly concerned when a man comes in with ED at a young age, if he has a family history of cardiovascular disease, so MIs in ages under 60, history of stroke in their parents at a young age, and especially if they have other medical comorbidities that are risk factors for cardiovascular disease like tobacco use, diabetes, etc. This would trigger me to consider doing an additional workup or referring them to my partners in cardiology or internal medicine, who would then perform an additional workup like an EKG or a stress test. And this is part of our guidelines. So this is the third point in our guidelines, that men should be counseled that ED can be a risk marker for underlying cardiovascular disease and may warrant evaluation and treatment. And this panel here on the right demonstrates just the increased risk, and that ED really can be a precursor to cardiovascular disease. For some men with ED, specialized testing and evaluation may be necessary to guide our treatment. And in my playbook, this really includes a couple things, including the penile duplex Doppler ultrasound. Other tests that have been described but I use less frequently are things like the Rigiscan or the nocturnal penile tumescence, biothesiometry to evaluate for penile vibratory sensation, cavernosography and cavernosometry, and penile arteriography. The bottom four options are used less commonly, and really penile duplex is one of the only mainstays of adjunctive testing out of this group. The penile duplex gives us a lot of data, and I'll kind of walk through what we obtain from this and the procedure. So this really gives us an objective vascular assessment of what's going on in the penis. This allows us to obtain data on a man's peak systolic velocity in the cavernosal arteries. And when peak systolic velocity is less than 25 to 30 centimeters per second, this is diagnostic of arterial insufficiency. It gives us data on end diastolic velocity. And when that is greater than 5 centimeters per second, this is diagnostic of a venous leak. Then we calculate the resistive index, and greater than 0.8 is considered to be normal. In terms of doing the procedure itself, what I do is I first obtain a pre-injection cavernosal artery measurement. I then deliver a vasoactive agent by intracavernosal injection, and this is usually in the form of L-prostadil because this is what is shelf stable and available in my clinic, but I do know practitioners who use Trimix. I then obtain post-injection cavernosal artery measurements, and I perform a Doppler flow study. That's really kind of the heart of this study. If needed, if a man has really good response to the medication, I reverse his priapism with phenylephrine. Peak systolic velocity is less than 25 centimeters per second, or when a man has a diagnosis of arterial insufficiency. This is associated with a 3-fold risk of major adverse cardiac events. So again, this has some real utility in identifying men who may be at future risk for cardiovascular disease. However, there are some limitations. From studies looking at penile duplex ultrasound, we've seen that there is high inter and intra-user variability. And there are some really important factors to when we're doing the exam. This includes the erectile quality, so the phase of the injection. If a man has had, if I do the exam shortly after the injection, I may get different results than if I let the medicine work for 15 or 20 minutes. Different ultrasounds have different sensitivities, and so this plays into the inter-user variability. And then what you see on the right is that when the probe of the ultrasound is positioned in different locations along the penis, we get different readings even in the same patient. So when the probe is placed at the cruce versus the proximal shaft versus the mid shaft, we see different readings of peak systolic velocity and end diastolic velocity. So there is some variability. I think it's just important to have a protocol that you use for yourself and you do it the same every single time so you know how to best interpret the results. There are also some false positives, and I have seen this particularly in young men with a lot of high anxiety. A high sympathetic tone can actually drive a false positive for venous leak. So important to know this in your paradigm for testing. When using a penile duplex ultrasound, I always ask myself, will this impact my management? In situations where I usually use a penile duplex ultrasound is a man of young age where I have concern for heart disease, so I'm evaluating there for arterial insufficiency. I also use it kind of in the opposite way, where I'm using it to evaluate for psychogenic ED, so men who may need reassurance that they actually have normal vascular function, with a caveat being that that high sympathetic tone can actually produce a false positive for venous leak. When patients have a preference to do this test, I will offer it. And then I pretty much always do a penile duplex ultrasound for evaluation of Peyronie's disease. This really helps guide my treatment, and that's a little bit beyond the scope of the talk, but happy to answer questions. Once we have all this data, it's time to turn to treatment. And we have a very deep toolbox. That's one lucky thing about treating ED. We have pills, vacuum devices, injections, other forms of vasoactive agents, and then of course, penile prostheses. And the AUA has made a very powerful statement where they say that they advocate the use of a treatment framework that is not predicated on men progressing through ED treatments in order of invasiveness or reversibility. Any type of treatment as an initial treatment choice is a valid choice. So the old adage of a man has to progress from PDE5 inhibitor to injections to an implant, that's not really how we do things. And I practice this when I meet with men. So this is a busy slide, but it really just summarizes the AUA guidelines and how we decide on treatment. So a man with ED comes in, and there you see all the different treatment options, including revascularization. Penile revascularization is really only considered in really one circumstance, and that is a young, healthy man who has a focal arterial occlusion, typically due to something like a trauma. That's where we would consider using that technology. Beyond that, there are all of the options that I sort of laid out previously, and I'll kind of go through them one by one. In the upper right-hand corner, you also see a statement about regenerative medicine, and I'll talk about that towards the end. So the baseline treatment for any man with ED is often phosphodiesterase 5 inhibitors or PDE5 inhibitors. And we have a variety of different drugs we can use in this space. The first sort of treatment on the block was sildenafil, and that is often used because it is generic and it is familiar to us. Similarly, tadalafil is also generic now in the United States, and it's also familiar. This is the brand name Cialis, sildenafil brand name Viagra. What is beneficial about Cialis is that it has a longer T1/2, so it stays in a man's system for longer and may allow for greater spontaneity. It doesn't have to be timed as precisely. And so it is a nice option for men, especially with children or if they're dating and really have a hard time timing sex. Additionally, there is no dietary restriction. So with sildenafil, this drug is, the efficacy is reduced by high-fat meals, and in tadalafil, it is not affected by diet. Two other drugs that I use less often are vardenafil and avanafil. Avanafil has the benefit of having a short T1/2, so it can be readily used on demand with a short duration of any potential side effects. So what are the side effects of PDE5 inhibitors? When I talk with patients, I generally counsel them that they are all similar and that the most common side effects are headache, facial flushing, GI distress or heartburn, and nasal congestion. Importantly, there are some absolute contraindications to use of these drugs, including the concurrent use of nitrates. So if a man has that on his medication list, I steer clear of PDE5 inhibitors and go towards other treatments, or untreated unstable cardiovascular disease. And that's really simply because we want him to avoid having strenuous activity, including sexual intercourse. So beyond the PDE5 inhibitors, I'll go to sort of the bottom tier, which again, I want to just reiterate that I do present these options all during my first visit. And I'll go through these kind of more advanced treatments one by one. So the next option is a vacuum erection device and use of a constriction band. You can see this in the diagram here at the right. The pros to using a vacuum device is that it is easily available. It's generally relatively cheap and it's reliable. And some studies have shown satisfaction rates. I didn't list this, but another powerful pro to this device is that there are no systemic side effects to use. It is just a local device that works by suction to pull blood into the penis, and then the constriction band works to trap the blood. The cons are that it is cumbersome to use and that the erection that's generated by the vacuum device doesn't really look or feel like a real erection to some men, and use of the constriction band may alter sensation. It's also challenging to use with Peyronie's disease because the cylinder, as you'll see, is straight. And if a man has a curved penis, it doesn't fit readily in the erect state into the cylinder. Some relative contraindications are the use of anticoagulation or an antiplatelet, which just can increase the risk of bruising. I really like a VED, especially in post-radical prostatectomy patients, because I do think that it is a low impact way to bring blood into the penis to help really keep that tissue healthy and prevent retraction after radical prostatectomy and loss of length. It's sort of what we call a penile push-up. So that's one setting where I do recommend it highly. Beyond the vacuum device, we have intracavernosal injections, which are commonly used as well. So the benefits to using intracavernosal injections, which are the administration of a vasoactive agent into the corpus cavernosum of the penis about 10 to 15 minutes before sex. as I mentioned, this is what I do prior to a penile duplex ultrasound. And so men who have that procedure get the first kind of preview into using those, using intracavernosal injections. And the benefits to it is that it's very efficacious. So these drugs work really well to bring blood to the penis. They work better in men who have profound diabetes or who have had a radical prostatectomy where those nerves may be impacted by their disease state. So really effective in men who have neurogenic ED. It's also relatively affordable. So a small vial has many uses and can be on the order of $100 US or so. And it's relatively easy to use. Once a man kind of gets the hang of using it, he is able to use it readily. The downside to using intracavernosal injections are needles, needles, needles. So some men really do not want to use needles, though I encourage them that this is a very tiny needle. It is a 27 or a 30 gauge needle, so it doesn't often, have pain, but some men do have needle phobia. The painful aspect to the intracavernosal injection is actually in the high blood flow and in the use of prostaglandins, which cause sort of an aching and burning in the penis in about a third of men. So my biggest fear about using intracavernosal injections is the risk of priapism. As I mentioned, these drugs work really well, and sometimes they can work too well. I recently read a paper regarding priapism admissions to the emergency department, and a large number of them since the advent of intracavernosal injections has been due to use of ICI. So we have to really counsel our patients well, and I'll go into this in the next slide. Lastly, the drug requires a specialty pharmacy and can only be used a few times a week just to avoid any risk of penile fibrosis. So what we see is a high discontinuation rate of this modality. And that is up to 80% of men stop using this after 1 to 2 years after their prescription. And risk factors for discontinuation include advanced age and advanced partner age, a history of diabetes, and a history of radical prostatectomy. We don't know exactly why men often choose to discontinue this, but I have seen this often in my practice. Regardless, when a man gets first started with intracavernosal injection, I always have him have a dedicated meeting with one of our nurses or our advanced practice providers to kind of go over teaching. I find that handouts like the one on the right and videos can be very helpful. There are YouTube videos. And so, the ubiquitous use of YouTube is actually very helpful in some of these scenarios where we need to do that teaching or men need reinforcement at home. I do a test injection in the office, kind of a low dose. And then I encourage them to use a similar dose if they have a relatively good response, because they often get a better response at home. They then follow up every 6 to 12 months to check for efficacy and to rule out fibrosis of the penis. The medications used for intracavernosal injection are also available in formulations as an intraurethral suppository. So this is, the brand name is Muse, and this is applied using a small applicator that is inserted into the urethra. The benefits of using this modality is that it does not involve the use of needles, and it is relatively easy, but again, some men do have qualms about sticking an applicator up his meatus, which is understandable. The drawbacks to intraurethral suppositories are that it has less efficacy than its injectable counterparts, and that it is dose dependent. These medications are extremely costly, and that is usually the limiting factor in most of the men that I've seen try it. Additionally, there is a significant proportion of men, about a third or more, who have pain in the penis, which can also radiate down to the legs and testes. And there is a report regarding some patient discomfort as well. Lastly, there are some other alternatives to the suppository, and these include topical gels, so gels placed on the outside of the penis, or intraurethral gels, which are sort of newer to the market and are available from national compounding pharmacies. These have sort of little data to support them, and neither, when I last checked, was FDA approved. So can we use combined therapy? And I often have men ask me, can I use the pills and the VED? And the answer is absolutely yes. PDE5 inhibitors and a VED have been shown to have really good improvements in rigidity and sexual satisfaction. When we combine PDE5 inhibitors and the intraurethral alprostadil, we see very good improvement as well, though that was a small cohort. And again, PDE5 inhibitors with intracavernosal injections may boost the efficacy for those men who fail either treatment. And when we combine these modalities, I recommend lowering the dose of either modality, so lower dose of PDE5 inhibitor and a lower dose of intracavernosal injections. And it's really important to counsel men on the safety of combining these modalities. The last modality I'll describe, and that I typically describe, I kind of go on an invasiveness pathway for them, but as I mentioned, I do describe this at the very first visit, is the penile prosthesis. So this is a hydraulic device that in the United States, we typically use the inflatable type of penile prosthesis. I had a previous picture of the semi-rigid, and happy to answer questions about use of semi-rigid versus inflatable. But because we use primarily inflatable penile prosthesis, I'll kind of go into more detail about that. The benefits to a penile prosthesis are that this gives a man a firm erection whenever he wants, as long as he wants. And it is really the only guaranteed way back to spontaneous intimacy with his partner. The other modalities I described, of course, are used on demand and do take time and are generally less reliable, whereas the penile prosthesis is highly reliable. It gives a man back spontaneity without impacting his urination, ejaculation, orgasm, or penile sensation, which can be changed in those other modalities. And we do see a high patient and partner satisfaction rate given the use of these penile prostheses. The drawbacks, of course, this is a surgical procedure. In my hands, this takes under an hour. It is minimally invasive, put in through a very small incision, either infrapubic or penoscrotal. And the recovery is relatively swift. I tell a man he has approximately 2 weeks where he will maybe sore. And then after that, he can resume sexual activity at 4 to 6 weeks post-op. And there are some implanters in the United States who have men back to sexual activity even sooner, so 3 weeks post-op. There are some minimal risks, of course, including infection, which is about 1 to 2%, depending on whether a man has diabetes or not. Mechanical malfunction, which is rare in the short term. There was a study from 2019 that showed that 2/3 to 3/4 of devices last greater than 10 years. And so that's a really reliable device. It's better than most car batteries, and most men are satisfied with the understanding that it will last about 10 years. One of the major drawbacks is perceived shortening. So I really set expectations early of how much length a man should expect after his penile prosthesis, because some men have a misconception that they may gain back length that they lost, but I help them understand that I can only put an implant in that his body allows me. So making that very clear early on is really key to success in implant surgery. And some of my discussion pearls are that I do bring it up early, but I never push it. I think it is a really good option for many men, so I just bring it up as that. It is good for any man who does not respond to PDE5 inhibitors and is healthy enough for sex and for surgery. I give a lot of resources because my job is primarily as an educator. So I give a lot of resources on all of these treatment options. And in particular, for the penile implant, I point them towards the SMSNA .org/patients website. I give them handouts specific to my clinic. I give them the websites for the 2 device manufacturers. And then I do link them with patient advocates. So these are men that I have previously treated with penile implant who offer to speak with new patients who are considering it and just kind of talk man to man about their experience. Sometimes patient advocates have their partners available, and that's always nice for partners of men who are considering implants as well. This is one area where I do consider doing a penile duplex, which just gives a man very objective data on whether he'll be a good candidate and whether something like a penile implant is kind of the best line treatment for him. So in general, my treatment philosophy around these options for treating ED is that I discuss all of them early. I go through that basically exactly what I just described to you, very detailed pros and cons of each therapy. And then after each trial of therapy, I bring the man back, the patient back, and I ask 2 questions. First, does it work? Do you get a good erection? And number 2 is, do you like it? Men, I find, should really stick with what they like and what works. And that's important because this should be a joyful thing. It should be, restoring his intimacy. And so he should really like it. And of course, we want it to work. One area where I did not talk yet about, but something that I care a lot about and I have written about in a review paper is advocating for lifestyle modification. So as I mentioned, the link between cardiovascular disease and ED is well established. And so we need to address those risk factors for both to really treat the patient holistically. And so this leads me to a discussion about smoking cessation, physical activity, increasing physical activity, weight loss, and reducing alcohol consumption, reducing or ceasing to use illicit drugs, which can negatively impact erections. I also discuss with them stress reduction. In particular, for young men who may have a psychogenic or anxiety-related component, it's very important to discuss the benefits of sex therapy. So I point them to the website of asect.org, and there are a number of sex therapy-focused podcasts that I think are a really great introduction to thinking about the mental aspect to ED and relationships. And so these are things that I talk about, and I also use my resources like dietitians and our internal medicine colleagues as well. So in this last segment, I wanted to discuss the regenerative medicines, which are being studied for the past 5 to 10 years and are being utilized even more than they're maybe even being studied right now. And the utilization of these regenerative medicines is primarily being done by non-urologic providers. And so I want to kind of at least give a briefing on what's out there and the purpose of the regenerative medicines. So the NIH defines regenerative medicine as the process of creating living functional tissues to repair or replace tissue or organ function due to age, disease, damage, or congenital defects. In the space of erectile dysfunction, there are 3 primary regenerative medicine modalities, and that is low-intensity shockwave therapy, stem cell therapy, and platelet-rich plasma. All of these modalities have similar proposed benefits, and that is to restore spontaneous erections and responsiveness to low-level therapies like PDE5 inhibitors by increasing angiogenesis and neovascularization. This is by means of increasing eNOS, VEGF, endothelial smooth muscle, and some other tissue markers that I'll describe, and also increasing neurogenesis. So after these treatments are used, we do see some increase in Schwann cells and neurite sprouting. So low-intensity shockwave therapy is a similar technology to what we use for stone treatment. This is where we use acoustic disturbances to propagate through tissue. And while the biologic mechanism of action is not completely understood in ED, we think that it's related to the rapid tissue compression and then subsequent expansion, which is also considered to be called cavitation in the penile tissue, so in the corpus cavernosum. This can cause localized cell membrane stress and thus production of these angiogenic factors like eNOS, nNOS, PDGF, and VEGF. Part of the difficulty in studying and using low-intensity shockwave therapy is the diversity of different devices out there. So as you'll see from this table, there are different types. There are electrohydraulic machines and electromagnetic machines, and they all use a variety of different penetration depths, frequency, energy density. They all involve the use of a handpiece, a gel applicator, and a shockwave machine directed towards the penis. And important considerations are, as I mentioned, the energy flux density, the hertz, so the number of shocks per second, and then the total shocks used. And the variety here has real implications in studying low-intensity shockwave therapy. So this next slide is very busy, but what I want you to see is just these are all studies on low-intensity shockwave therapy. You'll see here in the column of follow-up that the follow-up for these studies is pretty short, less than a year. And there's a lot of variety of different number of shocks, number of hertz, the frequency. And so there's a lot of variety across the board. It's hard to get kind of a synthesized understanding of benefit. There was a meta-analysis from Tom Liu at UCSF, and I'll describe the findings. So several studies have shown some benefit over placebo. And that benefit has been an increase of 2 to 4 points in IIEF. So whether this has a true clinical impact is yet to be borne out because that is just a small amount of points on the IIEF scale or the SHIM. The benefit is really variable based on the population. And again, as I mentioned, there are variable energy settings. So there's no clear definition of the optimal treatment protocol. Kind of a summary of who benefits are men with mild rather than moderate or severe ED. So as you'll see in this graph here, the men with severe ED in the light blue bar benefit much less than the men with non-severe ED in the dark blue bar. So those are the men where I would think that this has some potential benefit. When patients come to me with severe ED, I push them or I encourage them away from trying to use shockwave therapy. Men who are relatively healthy, who do not have diabetes, and who do well with PDE5 inhibitors are the men who are going to benefit most from shockwave therapy. Again, the treatment duration is unclear, the optimal treatment duration, and whether this treatment effect is maintained over time is also not well established due to short follow-up in those studies. Again, just defining that men with severe ED and diabetes do not have great success with this. This comes into play with men in the United States who are seeking out therapy from non-urologic medical providers. This is a procedure that is not covered by insurance and is often cash pay. And I caution them at the financial burden of using a therapy that is not going to be effective. The next modality in these regenerative medicines is stem cells, and this relies on the use of mesenchymal stem cells, which can be found in adipose, bone marrow, placenta, and urine. These cells are minimally immunogenic, so they can be either autologous from a man's own body or allogenic. What we think they do is they create a paracrine effect of intracellular biomolecules that then has some effect on immunomodulation in the penis. They release cytokines and growth factors and then recruit more endogenous stem cells to then create that process of angiogenesis and neurogenesis. There are a number of trials that have been done in this space as well. And again, I just wanted to highlight with this table, the N number in these studies is extremely low and highly variable with really minimal studies, minimal studies of controlled design. So there are small cohorts, no controls. We see a variable patient populations and treatment protocols across the board. There may be some signal of benefit, but certainly this is an area where we need considerably more studies. The last most common regenerative medicine used in ED is platelet-rich plasma. This is obtained by using whole blood centrifugation and spinning it down to really just get the component of the blood that is the platelet-rich plasma. This has a 4-fold number of platelets and growth factor concentration. And so this element is taken out of the lab, and it is mixed with a platelet activator prior to injection, and that's it. And then it's typically injected into the penis. This stimulates growth factor release, including PDGF, TGF-beta, sorry for the typo, IGF, and VEGF-1. And in animal models has been shown to result in neurogenesis, decreased fibrosis, and apoptosis. I want to highlight one very small study out of North Carolina, which looked at PRP injections for a variety of urologic issues, including ED, Peyronie's disease, and stress incontinence in a woman. The ED cohort was 11 patients, and the authors did find an increase in IIEF points above, although their baseline was not entirely clear. And in the entire group, 80% of patients elected that they would, or described that they would like to undergo further PRP treatment. Despite this data, and actually because of this data, the AUA has made some guidelines on these therapies. The authors of the guidelines say that for men with ED, low intensity shockwave therapy should be considered investigational. Intracavernosal stem cell therapy should be considered investigational, and PRP should be considered experimental. Echoing these guidelines, the SMSNA has written position statements as well. They strongly support the development of novel erectogenic therapies, so they really are supportive of the study of these and seeing what else we can use for men, especially restorative therapies. But that rigorous experimental data conclusively validating these mechanisms is currently lacking. And thus, the use of shockwaves, stem cells, or platelet-rich plasma is experimental and should only be conducted under research protocols. So kind of in summary, my take-home points on erectile dysfunction evaluation and management is that history and exam are very important, and that we should have a low threshold for cardiac evaluation, especially in young patients. We know that they share a common pathophysiologic mechanism, and so we need to be on the lookout for cardiovascular disease. I do think that penile duplex ultrasound has utility, but I do use it judiciously. And I mentioned the areas where I commonly use it. And that I do truly believe in what the AUA has said, that any treatment as an initial treatment choice is a valid choice. Again, I see myself as an educator. I just describe all of the treatment options for men, and I do select them and counsel them appropriately. I always ask the questions, does the medication or does the treatment work? And do you like it? So this really helps guide maintaining a certain therapy versus switching off that therapy and trying something different. Additionally, our visit is always a good time to reiterate the importance of healthy living. And I do talk about studies that show that diet, weight loss, smoking cessation help with erections. And I've had a number of men really work on their lifestyle because of that. Lastly, regenerative medicine. Oops, I'm going backwards. Lastly, regenerative medicine therapies are in need of more data. So with that, I just wanted to say thank you again to all of the participants. It's my true honor to be here. And, I hope that at some point we're all able to come together again as urologists. I look forward to staying in touch, and I'm here for any questions at all, either right now or feel free to email me or follow me on Twitter. Thank you.
Thank you so much for presenting.
My pleasure.
Does anyone have any questions or want to share how they're managing erectile dysfunction in their practice? Hi, Dr. Kigongo.
Yes, hi, Dr. Kate. I have some questions been listing along the way.
Yes.
And Dr. Marah, thank you for the presentation. The first thing about testosterone levels, you said you check it routinely. When most of the tests I've done for patients with ED turn out normal, many of my patients have normal testosterone. In that case, do you think I miss a lot by not doing LH? Because you said you always do LH with testosterone. Is it only useful in low testosterone levels, or even the normal ones you sometimes find used for the LH?
You're absolutely correct. That's a great question. It is mostly useful when the testosterone is low, but because I don't want a man, it's really more of a logistical thing that I don't want him to have to come back to the lab twice. So if I see the testosterone is low and then we have the LH already to sort of put it in context, I agree with you entirely that the majority of men have normal testosterone. But when we do see it's low, I find that it's nice to just have the LH as already, obtained so that we have some context for the low testosterone.
Okay. Like I said, I have a string of them. I hope you allow me time to ask all of them. In younger males, younger than 30 years, what do you find is the commonest cause for their ED? Most of them are not diabetic. They don't smoke. In our community, people don't smoke as much. What treatment options for those under 30?
I again agree with you. I think that most of the young men we see have largely what's referred to as sort of psychogenic ED. There are some new papers describing the kind of increase in young men's anxiety levels and just overall stress levels and how this manifests as erectile dysfunction. In these young men, I counsel them strongly on the option for sex therapy. That is in the AUA guidelines. It is a very good approach. It's hard for men to do because it is time consuming and they want a quick fix right away. And so I counsel them that it's not going to be a quick fix and it takes time. In the meanwhile, I do give them sildenafil or tadalafil generally to help kind of just support the erectile mechanism. But I do counsel them that if they're anxious enough, they will overcome, their anxiety will overcome the power of those drugs. And so anxiety is I tell them that it's the anti-Viagra. So it is a very powerful anti-erectogenic hormone, adrenaline. There are very few men, it's extremely rare to find young men with venous leak, a true anatomic cause of venous leak. And I would consider doing a penile duplex really strongly in men who have never had, young men who have never had good erections. They don't wake up with erections that are robust. those are men where I would consider that venous leak may be a possibility, but by and large, young men who come in and just had the sudden, loss of erections or worsening of erections, it's largely related to anxiety.
Okay. Last two, are there cases where you have to combine tadalafil with paroxetine? Then lastly, we usually have our side the gap in sex therapy. I saw you listed a site there. Have you looked at their podcast? Do you recommend your patients to go there, or you have other more authentic sites for sex therapy?
So the first question is about paroxetine for premature ejaculation. Yes, when men have, there's two primary groups of men who have issues with ED and premature ejaculation. One is the younger men who, again, have, I find that anxiety is a comorbidity and sort of can be linked with these two things. The other is older men who develop new onset premature ejaculation, which can be due to the loss of erection. So if a man is developing worsening ED and he's losing his erection faster, he may develop new premature ejaculation because the body wants him to climax before he loses the erection. So in the older subset, treating the ED is paramount. And in the younger subset, yes, we do treat both the premature ejaculation and ED with sildenafil and sometimes paroxetine. The number one treatment for premature ejaculation is behavioral therapy also. So that kind of ties into your second question, but I'll kind of go into that. When I'm treating premature ejaculation, behavioral therapy, sex therapy, using topical sort of numbing agents is the second line therapy, and then the oral therapies are third line, including paroxetine. And yes, I have prescribed both paroxetine and sildenafil. When men have really profound premature ejaculation, they want to do anything they can, including taking 2 pills. But it is something you have to consider. Do you want to manage someone on an antidepressant and then consider tapering them off when if they want to be off of it? So really requires close follow-up. With regard to therapy resources, in Seattle and where I practiced previously in Chicago, I had sort of a list of sex therapists in the area. But the alternative is to use, in the United States, we have a website called Psychology Today. And that has just any mental health provider in the area. Men can sort of sort by sex therapist. And so they can find someone in the area that they think they would connect with. And so that's one resource. The podcasts, though, I think are a really great resource for people anywhere. And especially for men who maybe not ready to talk with someone, but they just want to hear about what's involved in sex therapy and what sex therapists may be talking about. There are just so many podcasts, and I'd be happy to email you, some of the common ones that I talk with men about.
Thank you. I'll be happy to read those mails.
Great.
That is all. Those are my questions.
Great. Thank you so much. I appreciate it.
Thanks, Dr. Kigongo. Does anyone else have any questions?
Again, I want to thank everyone for coming to the talk. It means a lot to me to be kind of connecting globally. It's really awesome. So I look forward to continuing to connect. My email is here. I'm always available, either by email or Twitter. So thanks so much.
Yeah, thank you so much for presenting. And thank you to everyone else for attending. Okay.
Thank you so much.
Okay, bye.
Thank you.